to another podcast. Today, we're going to look at something a little bit different. We're going to have a look at thrombosis emergencies. Now, luckily, we don't really focus on thrombosis emergencies very often. Based on our demographic that we work with, a lot of risk factors are reduced for our demographic, but not impossible. It's one of those things that happens relatively regularly, and we'll look at the numbers in just a little bit. But to define it as best we can, a thrombosis is a formation of a blood clot. Now, this can be either partial or complete blockage of a blood vessel. A blood vessel can be a vein or it can be an artery. As long as it limits the natural flow of the blood, that will result in some sort of clinical sequela or some sort of clinical symptoms. Now, there's many factors out there that can impact our management decisions, and particularly our management decisions for the environments that we work in. But some of those include, on the bigger end of the scale, whether or not it comes from a venous or an arterial line, whether it's an acute case or a chronic condition, first versus subsequent episodes, whether the person has any associated risk factors or a known risk assessment, and how hemodynamically stable the person is. In our situation, we need to also consider the probability of it being thrombosis and the best course of action to get them to facilities that are better suited to support thrombosis emergencies. So we'll start with an introduction as always, and we'll just acknowledge that thrombosis is a very complex condition. It's a very complex, entwined condition that we could spend the next, 4 years discussing realistically. There's a lot of unusual presentations, one of those being DIC, which you've probably heard of. So disseminated intravascular coagulopathy is a state where somebody has a clotting and bleeding problem at the same time, and that can happen. So to give us a little bit of a narrow focus and a more probable emergency type focus, we're going to focus on the basic pathophysiology, if that is such a thing, of venous and arterial thrombosis. And those are DVT, pulmonary emboli, and cerebrovascular accidents. So they will be the main focus of today's presentation. So together, acute venous and arterial thrombosis account for the most common causes of death in the developing country, hence the decision to make a talk about it. Mortality depends on the location and the acuity of the actual thrombosis, so how much can actually get through a particular thrombosis. Now, myocardial infarcts and cerebrovascular accidents account for the highest proportion of thrombosis-associated deaths in the Western world. So they will be two that we will focus on today because they come with the highest mortality rate. As far as prevalence goes, it depends on how old you are. That's as simple as it is. So when you're very young, you have a 1 in 100,000 chance of getting thrombose, and it's usually associated with inherited coagulopathy problems or hypercoagulability states when you're in your infancy. As you go up in age, that probability 1 in 100,000 drops conveniently to 1 in 10,000 teenage years, 1 in 1,000 mid-adult years, and then 1 in 100 when we get up to the elderly state. So it really is quite prevalent in elderly state, which is why we have a lot of elderly patients on anticoagulant medication. Which brings us to our preventive measures. Now, we will spend a bit of time talking about preventive measures from a lifestyle point of view, but there are known risk factors, and we'll talk about a few of those really big known risk factors associated with thrombosis emergencies. But on top of known risk factors, certain patients will establish profiles that make them a higher risk, which will introduce protective measures or preventative measures like warfarin or a bunch of your roxabans and things like that they'll be on. Even Clexane during certain times like surgery, post-surgery, will often be done because these are known states where thrombosis occurs the greatest. People with AF is another example of who will receive anticoagulant medication. So just because they're known It doesn't mean that it's only the known factors or the highest risk people that get some sort of a thrombosis emergencies. So today we'll go through the clinical presentation, a little sensors that you can put out there in order to at least have the idea that someone has it, and then a pathway to go down to help quantify it that little bit further. The key message of today's presentation will be focusing on the need for identification, so the need for good clinical assessment, and then the absolute need for evacuation. Okay, evacuation equals good management when you put them in the right position. When you're dealing with thrombosis emergency, we need to remember the age-old adage that time is tissue. The longer you wait, the longer you mess around, the greater the damage, and the more probability of mortality there is going to be. So having a quick look at pathophysiology and mixing that in with known risk factors. I need you to cast your mind back to the clotting cascade. I'm not going to go through the cascade today. I really tossed it up whether I should go through it again, but we've done it enough in previous lessons that if you need to, you can go back to those particular ones to have a look at the clotting cascade. But just remember that there's certain pathways the clotting cascade must go through, and they usually denote either an intrinsic or an extrinsic factors. Intrinsic factors are mostly associated with thrombosis that we're talking about. However, in the presence of certain characteristics of the extrinsic factor, being tissue factor, that will increase the probability of clotting occurring. Now, all the way back in 1856, there was a guy called Rudolf Virchow, and he came up with a triad. And like everyone seems to do, he named that triad after himself. So the Virchow triad has been known and is still used today as predictors, if you will, for increasing thrombosis. And these three key factors are endothelial damage, which is denoted here as vascular wall damage. We have hypercoagulable states and circulatory stasis. Now, to look at those a little bit deeper, we can start at the top, even though that's not the most important factor. When you're dealing with a hypercoagulable state, sometimes that can be inherited. However, that is quite rare. When we talk about antithrombin 3 deficiencies, anything like that, that will come up with a hypercoagulability state. But most of the time, this state is acquired artificially from medication, things like oral contraceptive, estrogen hormone replacements, inflammatory conditions, pregnancy, surgery, trauma, even certain infections, especially sepsis or kidney-based infections, can cause this hypercoagulable state. And because of this state, you're obviously more likely to clot, hence the name. So certain characteristics that a person can have, and even our demographic can get into, can mean that the result of that existing problem or that existing state can make them more probable to having thrombosis. And when you couple that with the other two, it just increases the probability. So circular stasis occurs either on a large scale, when we're dealing with loss of mobility, the people that aren't moving, paralyzed in beds, people that have lost a amount of blood and they're lying on hard surfaces as well, can create some sort of stasis or microstasis within the vessels that can cause it, and that usually comes down to obstruction. So whilst obstruction is generally associated with cancers and obesity or even a pregnancy, it can occur on a microthrombin level. And that is definitely the case when we're dealing with the heart, but it can also occur down in the lower limbs when somebody's in a state, they've already got the inflammatory syndrome happening as a result of sepsis or trauma, and they end up in a hypercoagulable state, and then they end up with microthrombins forming from a circulatory stasis, which forms into a thrombin. And that thrombosis can then break off and become an emboli, and that's when things can actually cause problems like DVT or PE in particular. Okay, so it doesn't have to be these large-scale things that cause these thrombosis emergencies, but things like atrial fibrillation or left ventricular dysfunction pretty much make a pool within those chambers that particular aspect of blood is no longer moving. And when those pits of blood aren't moving, there's a probability of the factors combining, the clotting cascade occurring in the absence of any triggering factors or actual need for clotting occur, purely by the blood not moving around. Okay, and the last one is the most biggest factor when dealing with the Virchow's triad or when dealing with thrombosis, and that is vascular wall damage. In the presence of a vascular wall damage, what you get of intrinsic and extrinsic factors, like tissue factor being released, but you also get collagen fibers being released into the bloodstream, and these attract platelets. And once collagen fibers attract platelets, it all of a sudden starts the clotting cascade internally. Now, when you couple this with atherosclerosis and plaques, you pretty much just created a platform for these thrombin to grow. And when they grow, they obviously get larger, they form into that fibrous mesh, and then they can break off and become an emboli. Okay, so that really breaks down the three states that increase the probability of a thrombosis emergency occurring, or even thrombosis in the chronic sense occurring. At the end of the presentation, we'll link this to risk factors as well, but we'll stick to the emergent sense and we'll refer back to this Virchow's triad during our management and in particular our clinical presentations that we look into. Speaking of which, we will start with deep vein thrombosis. So deep vein thrombosis, as you could imagine, is a thrombosis of forming in the veins, often in the legs. And when it goes in the legs, it pretty much stops the vascular return from the feet. So the artery is still pumping down, and then you've got a block, partial block, full block in the calf usually, and you end up with a backup of all of this fluid. That backup increases hydrostatic pressure, leaks in the interstitial space, and then you get the signs of inflammation and edema as well. So the biggest thing we can do is keep our feelers out for lower leg injuries. Okay, lower leg states that people come in and they say that they've got some sort of swelling, some sort of pain, that sort of thing. And all you need to do is have a suspicion. Now, if the suspicion is such that it could potentially be DVT, then we do something known as a Wells score. So if someone comes in with calf swelling, pain in that calf but not the other, foot vein distension, things like that, then we really need to do the Wells score. And what the Wells score is used for, it's used to weigh up the probability of it being a DVT or being something else. So before we start, if you look at the very last criteria, which is could patient have an alternative diagnosis, at least as likely or more likely than DVT. If that's the case, like an insect bite, like a cellulitis, like a musculoskeletal injury, we -2 already. And then we go to the other. We look for, do they have paralysis or muscle weakness? You know, recent bedridden, entire leg swelling, tenderness, things like this, and we allocated a point. I'm not going to go through the whole list because you can read, and this is available in our protocol. The point is we give it a grading, and that grading will tell us whether or not DVT is likely, and then we can go through the management process of DVT from our point of view. So if you get a score of 1, still think it could be DVT, but they've really only got 1 point, then we send them away for a blood test. If we still believe it could be DVT, then send them away for a blood test. The blood test is called a D-dimer. Now, don't get involved whether or not it's a good test or not. It's the one that's used for this. So that's what's going to happen. Okay. Now, from there, they need a decision based on an ultrasound. Dopplers have been used in the past, but ultrasound is really the biggest probability. You make a phone call to the doctor, and if you were to carry fractionated heparin like enoxaparin, then you can consider giving that as well. But that's often based on time and how long it will take to get the results back. Now, for those that aren't aware, a D-dimer is obviously a blood test, but it's a very popular, simple blood test that's used to measure the degradation product of cross-linked fibrin. Remember, when a clot occurs, it's known as a cross-linked fibrin, and normally, in normal stasis, these levels are low. But when you have an increased level of fibrinolysis, so the actual plasminogen is breaking down the clot, then the D-dimer score will be higher. And because in the case of a thrombosis emergency, we often have a thrombosis that is so large that it's causing damage, or more likely it's broken off as an emboli, which is now subject to more fibrinolysis, we have higher D-dimer scores. So when you come up with a higher score, it's known as D-dimer positive, and that obviously supports the management. If you ever get a positive D-dimer score, then that's basically saying that it's positive, or more probably positive, for a thrombosis, and you really need to get to an ultrasound. In the event you've gone your well scores for DVT and you come up with a score greater than 2, then you need to weigh up where you are. You need to send them to a facility that has ultrasound. If that's not possible, then you really need to call the doctor. You really need to go to a place where they can have a D-dimer test and get fractionated heparin. Enoxaparin is an example of that. They will still need an ultrasound at some stage. Once they get positive diagnosis, then they get put on a bunch of anticoagulants in order for the body to break down the actual clot, and they get put under management from there. So from our point of view, the biggest role we play in DVT is index of suspicion, quantifying it with a well score, and then evacuating them to an appropriate facility after making a call to the medical officers. It seems relatively simple, and it does quite start in quite a simple state. When we move on to pulmonary emboli, that's when things can get a little bit more dangerous, because we're dealing with an embolus that has blocked the vessels of the lungs. Now, this can result in some relatively common symptoms, especially when we're dealing with infection or trauma. So you really have to get a good history from the individuals to get your index of suspicion. Now, there's a difference between a PE, pulmonary emboli, and a massive PE. Massive PE obviously has a greater effect on a larger portion of the lungs, therefore creating a bigger backlog of pressure and almost like a stasis of the lungs for anything thereafter. So if blood's not getting to the aspects of the lungs, then we have no blood in the capillaries, we have no way to transfer oxygen, we have no way to get rid of waste, all these sorts of things happen, and obviously that has a flow-on effect with our symptoms. So in the smaller PE case, we often get shortness of breath because we have that need for increased oxygen. So we breathe more. Okay, it makes sense. It can result in slight hypotension, but we're talking really minor changes as well as an increased heart rate. You can get a small decrease in SpO2. If you're not having that emergent sign, then we do a well score for PE. Okay, that's pretty much it. So if you think it could be a PE but they're not a medical emergency, then we do a well score. If we think it could be PE but we're in the state of a medical emergency, then we're really looking at evacuating that person now. So if their SpO2 is dropping below 94, their systolic blood pressure is below 90, it's a massive PE, then we really need to act a lot faster. We need to get cannulas in. We need to call doctors about maintaining perfusion, because sometimes too much fluid can actually do the opposite to what you're trying to do and compound the issue. Okay, so you really got to play it by ear. And giving oxygen can have the same effect as well. You want to prepare for the ability to maintain perfusion. You want to prepare for the ability to give oxygen. We'll discuss management in just a little bit, but these things are paramount. Now, like our acute coronary syndrome, the use of tenecteplase can be considered in massive PE. And it's pretty much under the same guise that we will not go into today around time it's going to take to get to a facility that can do cath labs, open up the actual vessel themselves. Okay, so just know that this is put on the same pedestal, if you will, as acute coronary syndrome. It is a medical emergency and it can need massive medical intervention. But looking a little bit closer at the manager itself, When you're dealing with a non-massive PE, okay, remember when you're dealing with a massive PE, you are focusing purely on evacuation, management, and making phone calls for emergency care. If it's a lower end, they still absolutely need to evacuate, but you can do a little bit more clinical assessment. So you follow the Wells score, as we discussed in the other one, and we go through the probability with the same idea as we just spoke about with the DVT. A little bit different, but obviously it involves D-dimer, and then it involves the use of anticoagulants and things like that, depending on the score and depending on the positive nature. Whilst that is happening, or even if that can't happen, if we're waiting for evacuation, we need to do a good chest assessment, and we need to try to quantify those risk factors that are included in that Wells score. We only give oxygen if SpO2 is less than 94. Giving too much oxygen in a case of thrombosis can bring up the probability of free radical and reperfusion problems, so we obviously need to be careful with that. 12-lead ECG is very important. The effects from a PE can have arrhythmic effects on the heart, and pregnancy tests can be also a good idea, particularly for the management, but also for the associated risk factors. We shouldn't be scared to give these people analgesia. Just obviously make a phone call for advice if you need to, and give them the appropriate analgesia that can support them. Bottom line with PE, we often can't manage it in small facilities. It is a medical emergency or can escalate to a medical emergency very quickly. It will need tests on confirmation. They will often go on infusions of heparin in order to manage them, if not going to a cath lab in order to open up one of these pulmonary vessels in order to allow blood to get through. Our side, suspect, quantify, evacuate as soon as possible. The last one we'll talk about is a cerebral vascular accident or a transient ischemic attack. Basically, the difference is when we're dealing with a transient ischemic attack is it's short-lived. It's a CVA, but it recovers. It's like a mini stroke, as people have called it in the past. It doesn't really often result in long-term damage, and then that's pretty much it. The CVA side of the house is very, very dangerous. Time is tissue, time is brain, as it says. So we need to be aware of the signs. Now, the campaign have got really good at passing face out there to the general community, so people have somewhat of an idea. But as clinicians, we really need to think of the big five. And if we see somebody with a combination of the big five, then we really need to suspect CVA, TIA, and we need to manage it appropriately. So the first one is numbness or weakness. Okay, so there's some effect on the actual motor aspect of the brain, so you get weakness in a limb or a side of the body is usually where it occurs. You get aphasia, you get the inability to speak, or sometimes even just profound confusion as well. Visual disturbances are very, very common, as well as dizziness or loss of balance. So effects on the actual coordination centers like the cerebrum, that sort of thing can occur. Headache is a big sign, but it's very hard to obviously quantify by itself. Okay, so look for the weakness, speaking problems, visual problems with association with headaches to suspect CVA. But just realize that fast isn't the only one. That's just used to denote simple things for non-clinicians to call an ambulance, call for help in order to get somebody assessed. Once it comes to the management is the same. You suspect a CVA, you arrange for evacuation. We do a BGL because a BGL can have similar symptoms to a stroke, and if it is low glucose, then we can fix that and see if the symptoms hang around. Get a history, try to figure out what they're feeling, how bad the stroke is, when it started, what sort of risk factors they're on, and if there's been any associated seizure activity or loss of consciousness can mean a lot. When we're dealing with the brain as opposed to a PE, we work with the less than 92% rule. Okay, so we really need to be on our protocols as far as oxygen for the same risks that we spoke about: free radicals, reperfusion injuries in the brain. So if their SpO2 is less than 92, we give them enough oxygen just to get over 92, and we leave it at that. 2 cannulas is a great idea, as 2 is an ECG, but only if it will not delay evacuation. Evacuation is key for somebody who has a suspected CVA. It is possible to give analgesia to someone with a CVA, but it is best to make a phone call first because it may impede future examinations. If you're going to a place with a CT, they usually won't have a problem at all with you giving analgesia, but make sure you make that phone call just to check beforehand. All right, we talked a lot about the management, and in reality, we've talked a lot about the clinical presentations and our need to be real about what we can do with these patients. So another thing we can do is educate the people that we work with and educate our patients before they get to the state of a thrombosis emergency, and know that there are known risk factors out there associated with an increased probability of clots or thrombosis forming in the body, and they all link to that Virchow's triad. So everything you read on this board in front of you has a direct link to Virchow's triad. Some have multiple links to the lines of Virchow's triad. Some of those, as you can see, are well within the control of the person, the lifestyle of the person. Okay, some of those are unavoidable. In the state that it's family history, then obviously that's just bad luck and it needs to be managed accordingly as to cancer. Okay, don't tell people not to get cancer, because if they could agree, they just would. Okay, but telling someone that bad diet, sedentary lifestyle, obesity, smoking, states of dehydration can increase the probability of clotting problems is something that should definitely be considered. Hormone therapy should definitely be considered, whether or not it is worth the risk for someone to go on hormone therapies based on the reasons that they're taking it. So sometimes it's our job to educate people on the preventative measures in order to decrease the probability of thrombosis emergencies, given that if they get caught in a situation that we often work in with a thrombosis emergency, there's very little that can be done on the ground. The medications that are required often require refrigeration, which means we can't really do it that well. We need advanced pathology, well, advanced as far as we're concerned for pathology, and then we often need higher management than we can provide. So get good at the identification of these thrombosis emergencies, get good at taking good clinical assessments, and know your evacuation chain prior to going out on missions or tasks. But until next time, take care.